So we're just gonna go over the outline. First, we're going to define paracentesis, talk about indications, contraindications, relative contraindications, what you need, what you have to do for this procedure, and then some complications. So paracentesis, it's basically a procedure to remove ascites from the peritoneal cavity. And ascites, by definition, is the abnormal buildup of fluid in the abdomen, technically more than 25 mLs. And we're most familiar with this straw color fluid that we see in liver cirrhosis, but it's also important to remember there's also hemorrhagic, cloudy, or chylous ascites. So what are some indications? So one indication is if a patient has new onset ascites, we have to find out what may be causing it. Is it like a portal hypertensive cause or a non-portal hypertensive cause? So basically you want to draw the fluid, look in the albumin, and plug into that formula, the serum ascites albumin gradient. And based on the number you get, we can get a better sense of what may be causing the ascites. Another indication is to rule out infection. Most commonly, you want to rule out SBP in acidic patients with fever, abdominal pain, and abdominal tenderness. Paracentesis should be performed promptly in these cases because delays or failure are associated with increased mortality in patients with SBP. The only caveat is that SBP can also be asymptomatic. So you want to perform a diagnostic paracentesis for any change in clinical status of a known cirrhotic, including even hospital admission. All right. And another infectious cause could be secondary bacterial peritonitis, which is basically infection coming from intra-abdominal surgically treatable sources of infection, such as perf appendicitis, perf diverticulitis, cholecystitis. Third indication is whenever a patient with ascites develops any clinical deterioration, such as fever, abdominal pain, tenderness, hepatic encephalopathy, metabolic acidosis, deterioration in renal function, etc. And also remember that, again, you can find things such as like chylous, hemorrhagic, or eosinophilic ascites. And the last indication is if a patient has discomfort and dyspnea from tense ascites, we can perform what's called a therapeutic tap, where we remove more than 5 liters of fluid to help relieve their symptoms. All right, some contraindications are clinically apparent DIC and hyperfibrinolysis. You want to treat DIC with platelets and FFP, and hyperfibrinolysis with antifibrinolytic agents. Surprisingly, though, elevated INR or thrombocytopenia are not contraindications. You do not want to transfuse FFP or platelets prior to these cases because there are no supporting data for the benefit of transfusing. In fact, you can actually delay the procedure, expose the patient to risk of post-transfusion hepatitis, and it's pretty costly.
That's an important point. You don't need to get coag on somebody you're going to do a paracentesis on.
Yeah.
Because most procedures, you can do an LP, you probably have coag. Paracentesis, you don't need coag, and you shouldn't use that as a decision point.
That is very correct. All right, so some relative contraindications are massive ileus with bowel distension, bowel obstruction, surgical scars in pregnancy. Basically, you don't want to puncture any bowel, solid organs. You don't want to puncture the bladder, the uterus. You don't want to puncture the baby. And I mentioned surgical scars up there because scars are associated with tethering of the bowel and vessels to abdominal wall. So if you are to perform this procedure, stay far away from scars when choosing your site. In pregnancies, second and third trimester pregnancies, you want to do a supraumbilical approach. And in this day and age, we have technology called ultrasound, and it's very useful in a lot of procedures, but especially useful and indicated in these relative contraindications. So now, items you need. This is a basic paracentesis tray that you'll see in the ED. I'm just going to go over all the stuff you need from the top. So this is a sterile procedure, so you need all your sterile equipment. Next, you need lidocaine, a syringe for the lidocaine, a 25 gauge needle for superficial injection, and a longer 22 gauge for deeper injection. You also need this is the main character. You also need the 14 to 18 gauge angiocath needle or commercial catheter needle system. If the patient's super obese, you can use a spinal needle. Stopcock is optional. You can use a scalpel or large bore needle to make superficial incision. You need a 60 cc syringe to draw samples. You need collection tubes for samples. So sometimes in the tray you get 3 tubes. One is for biochemistry, one is for cytology, and one's for microbiome. You can also use an EDTA tube for automated cell count, and blood culture bottles if you're thinking of doing cultures. And remember to get transfer tubing or adapters for these vacuum bottles. And finally, you need large volume collection tubing with needles if you're planning to do a therapeutic tap. You want 1 to 2 liter vacuum collection containers, but if you don't have these, you can always connect the tubing to suction containers and then suction in the wall. And finally, you want gauze, bandage, or tegaderm for after the procedure. So some steps. First, you want to consent and discuss the risk of procedure with the patient. If you're doing a lateral approach, you want to position the patient supine with the head of the bed slightly elevated. If you're doing a sub-umbilical approach, it's best to put the patient left lateral with the cubitus because the bowel floats up. So you avoid puncturing the bowel. Again, let's talk about the location. So if you're doing a lateral approach, you want to do the right lower quadrant and left lower quadrant. You want to be 2 to 4 cm medial and superior to the superior iliac spine. You should be lateral to the rectus sheath to avoid the inferior epigastric arteries. And usually the left side is preferred over to the right because the left lower quadrant has a thinner abdominal wall and greater depth of acidic fluid. If you're doing a sub-umbilical approach, you want to do 2 cm below the umbilicus midline. And remember, the bladder should be emptied before the procedure. So either have the patient go pee, or if they have a neuropathologically distended bladder, you have to cath them. And again, for pregnant patients, you want to do a supra-umbilical approach. And then you want to avoid sites of skin infection, visibly engorged subacute veins, or abdominal wall hematomas. And you can find the site with ultrasound. Basically, you want to look for acidic fluid with no loops of bowel or solid organs. And you can ask the patient again to turn slightly towards you so the bowels will float up. All right, so steps for performing procedure now. First, mark the site. You can do it with a syringe or a marker. Then prep the skin, don gloves, and drape the site for sterility. Next, you want to anesthetize the skin with a wheel lidocaine and then anesthetize the tract. Remember to pull back on the syringe to make sure you're not in a blood vessel. If you do aspirate blood, stop, withdraw the needle, and change your position by 1 to 2 cm and try again. You do this until peritoneal fluid enters the syringe, and then you inject additional anesthetic to anesthetize the highly sensitive parietal peritoneum. All right, and then next you prep your tubing, scalpel, needle, catheter. You cut just large enough on the surface of the skin for the catheter to fit. Again, you could also use a large bore needle. And then you want to advance the catheter using an angular or Z-track technique, which we're going to watch a short video about.
In this video, we will demonstrate an angular entry technique in which the cutaneous site of insertion does not directly overlie the site of penetration into the peritoneal cavity. Alternatively, a Z-tract technique may be used. In this method, the cutaneous tissues are pulled 2 centimeters caudad prior to needle insertion and advancement through the peritoneum. When the catheter is withdrawn at the end of the procedure, the cutaneous entry site will retract to its original position.
And this is basically just to minimize acidic fluid leakage after the procedure. All right, so as you advance the catheter, provide negative pressure in the syringe until it starts to fill with acidic fluid. It's okay if you nick a little blood vessel and see some blood, that's fine. When you pierce the peritoneum, you might feel a sudden loss of resistance, or like in the video you just saw, the patient may jump a little. But you can then confirm with ultrasound, and this is usually what you see. And once you confirm your position, you can guide the plastic catheter into a peritoneal cavity and remove the needle. Then if you want to draw any samples, attach the large 60 cc syringe to the catheter and transfer to appropriate tubes and bottles. And for large volume therapeutic paracentesis, connect the tubing to vacuum sealed containers. Remember, this is a non-sterile procedure. I mean, this part is non-sterile, so you either have a partner helping you to put in the needle, or if you are transferring the fluid to the bottles, remember to change your gloves before touching the patient. Again. And finally, after you're done, remove the catheter and place the dressing. So some complications, in 0 to 0.93% of patients, you can get some hemorrhage. In this picture, you see a CT scan showing injury to the inferior epigastric artery. You can also get vessel lax to the aorta, mesenteric artery, iliac artery. You can get abdominal wall hematomas, mesenteric hematomas, and inferior epigastric aneurysms. Another complication is infection. It happens in 0.58 to 0.63% of patients. You might also see patients develop abdominal wall abscesses. Another complication is bladder or bowel perforation. It happens in 6 out of 1,000 patients. And that's why you want patients to void if you're doing subumbilical approach. And if patients don't have bowel distension, actually most bowel perfs are self-sealing. So that's why the relative contraindication is for distended bowels. And finally, for large volume paracentesis, 15 to 20% of patients over hours or days may develop hyponatremia, impaired renal function, hypotension. Surprisingly, the hypotension is mostly asymptomatic, but if you do get a patient with symptomatic hypotension with abdominal pain, you might want to be suspicious for acute bleeding into the peritoneum. Some physicians try to mitigate the risk of hypotension by using, again, the angular Z-track method to prevent persistent acidic fluid leak. Some other physicians also try to use intravascular volume expanders like albumin immediately after the large volume paracentesis if removing more than 5 liters. But no study has shown direct survival advantage of using albumin, and albumin does not usually prevent asymptomatic lab abnormalities. So before we wrap up, any questions? Nope. Okay. So in summary, paracentesis, it's both a diagnostic and therapeutic procedure. We do it to analyze intra-abdominal fluid contents to aid in our diagnosis. It's also used to help patients feel better. And some pearls again, do not give FFP or platelets for elevated INR or thrombocytopenia. It's not contraindicated. Use the angular Z-track method to prevent fluid leakage after a procedure, and also consider albumin and large volume paracentesis. All right.
Just a couple comments, all right? I think that one, when you're numbing them up, you should use lidocaine with heavy, so you get much less bleeding at the site you stab. When you're using the needles that come with the kit, a lot of them will have a retractable tip, meaning it's got a spring-loaded like blunt end. So when you push it against the skin, the spring-loaded part will go in, and you can penetrate the belly wall. But then as you get in, the part pops back out, and you can't penetrate the bowel wall. So it's important to use the correct needle when you're doing it, if you can find it.
Okay.
The final thing I'll say is this is all attending dependent on which you'll do and which you won't. If you work with me, you'll almost never do that because there's no real indication in the emergency department to do it. If they're febrile and they have a possible of SVP, then I'm all for it. But just because the patient says my belly's bigger is not a reason to do it in the emergency room. That emergency room never ever gets cleaned. It's disgusting. There's all stuff on the walls and the beds. The patient is much better off getting this done in a sterile procedure suite, like in GI clinic or something like that. You guys should not be doing it in the emergency room, in my opinion.
I disagree.
But there are other attendings who enjoy doing procedures and want to take a bigger risk that they want to take.
I think the difference is that the risk of SVP and the mortality associated with SVP is really high, which is why the national recommendations are you should have a really low threshold to do a paracentesis on anybody, as Ryan said, with a change in symptoms. So I think if they come in and it's just their standard ascites, then you can have a conversation with the patient because they're like, it's uncomfortable, right? They have difficult time breathing, and sometimes they just want to take a few liters off so they can maybe sleep for a day or two. Because anybody who has that much ascites and you're going to take 4 or 5 liters off, that fluid will be back within days. So you're not like having a huge impact on the patient. So you should really be doing mostly the paracentesis to rule out SVP, or, but sometimes, the patients are really uncomfortable. They don't have access to a GI suite or to GI. It'll take them weeks to get an appointment. So we're their best shop. So that's a conversation you can definitely have with your patient, and obviously you're attending. And I do think they really have to have a low threshold for SVP because the mortality is so high, and you should probably not wait. If you think it's SVP, like they're febrile, just treat them. And does anybody know what antibiotics used for SBP? What's the most common bacteria for SBP? It's the answer, pretty much the same bacteria for everything under the diaphragm. It's always the same.
Metronidazole?
It's E. coli, right? So E. coli is pretty much always the most common bacteria under the diaphragm, and ceftriaxone or second generation cephalosporin should probably treat that just fine, unless the patient has, unless the patient's like super sick, then you might think of something like Pseudomonas, or if they're doing like peritoneal dialysis, then you can think about things like staph. Those patients will all pretty much get SBP at some point if they're doing peritoneal dialysis. But I think the important thing is that you know how to do it, and you don't have to do a large volume paracentesis. If the patient's not having difficulty breathing, you can literally just take a 22 gauge needle and a 60 cc syringe, take off enough fluid to be able to send the test off, and that's okay. That's a diagnostic tap. Not every patient needs a therapeutic tap of 3 liters. And the other thing in terms of albumin, I never give anybody albumin because I never take off more than 5 liters. Because the utility of albumin is really unclear, and nobody needs more than 5 liters taken off, because if they need more than 5 liters, it doesn't really matter. If you take an extra liter or 2, it's going to be back within a day. So you're not really, usually 5 liters is enough to get their symptoms to the point, where they're going to be a little more comfortable.
I agree with that, Checker. If you think there's SBP, if there's pain, fever, all the mental status, they definitely need it. But for the guys who come in and say, I want the fluid taken off because my belly's big, I would never do that in emergency. The chance of getting a complication like bleeding or bowel perforation, if you don't put a needle in, is 0. But the chance of you getting a complication is not 0 if you do the procedure. So I personally would not do it. We have done this for many years now. It's up to you guys and your risk threshold. I will tell you that when I was a resident, I was a procedure board. I did more procedures than any other resident, and I would have done them in a heartbeat. But after seeing complications, I just don't do them anymore.
Came in on vacation to do procedures.
Okay, so just to summarize what Dr. Silverberg and Dr. Schechter said, you can use lidocaine with epi for anesthesia. Usually, we don't perform many paracentesis in the ED unless there's suspicion for SBP, where you'll have a very low threshold to perform this procedure. Otherwise, if it's for therapeutic taps, usually we don't do that in the emergency room, because the complications are just not worth it if their volume is just going to come back in a few days. And even if we are to do therapeutic taps, we wouldn't usually remove more than 5 liters. Maybe remove like 3 liters, because again, it's just to relieve the symptoms for a little.
Not over 5.
Not over 5.
That's why it's
$4.99.
Okay, 4.99 liters. Because afterwards, then you have to consider albumin, which is not proven. There are no real studies proving the benefits of albumin for preventing post large volume paracentesis complications. All right, so here are my sources, and thank you.